Welcome back. Today, we're doing a deep dive into a microbe that has literally shaped human history. It's caused some of the most devastating pandemics ever, and, it still poses a pretty significant threat. We are, of course, talking about the bacterium behind the Black Death, Yersinia pestis.
Now, just so you know where all this is coming from, we've pulled together all the information for this briefing using a Gemini deep search. All the visuals you'll see are from MicroCanvas. And hey, if you really want to get into the weeds, you can check out the full list of primary sources in the notebook we've linked for you.
To really get why this organism is such a big deal, you have to look at its history. I mean, that statistic you see on the screen, that isn't just a number. That represents a complete societal collapse. And understanding that context is so important because it's exactly why Yersinia pestis is handled with such extreme caution even today.
So, here's how we're going to break it down today. We're going to follow a classic bench-to-bedside path. We'll kick things off with how the disease actually looks in a patient. Then we'll head into the lab and walk through the entire diagnostic workflow. After that, we'll cover the latest on treatment, and we'll finish up with the absolutely critical infection control measures.
Okay, let's dive right in with the clinical picture. It always starts with a patient, right? And with Yersinia pestis, the disease can show up in one of three pretty distinct ways. It all just depends on how the person got infected in the first place. So, the one you always hear about is bubonic plague, and it's defined by that classic, painful, swollen lymph node, the bubo. But if that infection spills over into the bloodstream, it can become septicemic plague. That's actually where the name Black Death comes from, because of the gangrene it causes. And then there's pneumonic plague. It's the most dangerous because it's not only incredibly lethal, but it's the only form that can spread directly from person to person. So you can see why spotting these syndromes fast is the first crucial step. Okay, so once a clinician even suspects plague, the pressure is on. That one phone call to the microbiology lab kicks off a very specific, very high-stakes workflow. Let's walk through that diagnostic path step by step.
You can kind of think of this pathway as building a case, right? You started with the first clues you might get from a direct gram stain. Then you gather the hard evidence with culture, that's still the gold standard. And finally, you nail down the identity beyond any doubt with molecular and biochemical tests. It's a really nice mix of old school and cutting-edge microbiology.
So under the microscope, that first clue we're looking for is a plump, gram-negative coccobacillus. And of course, the textbook picture we all learned is that classic safety pin look. That comes from what's called bipolar staining, where the stain just seems to gather at the two ends of the cell. Right, but here's where it gets tricky, and this is a huge potential pitfall. That classic safety pin thing, well, it shows up much, much better with special stains, like a Gemsa or a Weissen stain, which are great at showing those polar bodies. But on a routine, everyday gram stain, it's often really faint, inconsistent, or just not there at all. And this is the key takeaway. You absolutely cannot rule out Yersinia pestis just because you don't see bipolar staining on the gram. Okay, so moving on to the culture plate, Yersinia pestis is, well, it's a bit particular. It actually prefers cooler temperatures, around 28 to 30 degrees Celsius. That means in a standard 37-degree incubator, it grows pretty slowly. And that's a real challenge because at 24 hours, you might just have these tiny pinpoint colonies that are super easy to miss. It's not until day 2 or 3 that they really grow out and develop that classic fried egg or hammered copper look.
For a really definitive ID, multi-target PCR is the way to go. And it's a brilliant strategy, really. You can think of the Plas gene as your screening tool. It's like casting a wide net. It has a super high copy number, which makes the test incredibly sensitive. You're not going to miss a potential positive. Then, you follow up with the CAF1 gene. That's your confirmatory tool. It's like a specific key for a very specific lock. It's highly specific to Yersinia pestis, so a positive here gives you a rock-solid, confirmed identification. This table just perfectly sums up one of the key diagnostic features of Yersinia pestis. It's, well, biochemically, it's pretty boring. It's remarkably unreactive compared to its close relatives, and that's actually super helpful. This simple panel of 3 negative reactions, no motility, urease negative, and ODC negative, gives you a super clean, super clear way to tell it apart from Yersinia pseudotuberculosis and Yersinia enterocolytica.
Okay, so we've got our identification. The focus immediately pivots to treatment. And when you look at the guidelines, you see a lot of agreement. But there are also some important little differences that are definitely worth pointing out. So if we look at the Dutch guidelines, for instance,
They really prioritize aminoglycosides, so gentamicin or streptomycin, as the first-line treatment for all types of plague. The standard course is 10 days. And you'll notice, for that rare but really severe complication of meningitis, they recommend chlorphenicol because it gets into the central nervous system so well.
Now let's compare that to the international CDC guidelines. Here, you see a bit of a different approach. They put fluoroquinolones like ciprofloxacin right up there with aminoglycosides as co-first-line options, especially for the really severe septicemic and pneumonic forms. And that's really important clinically because it gives doctors more flexibility depending on what drugs are available, patient allergies, or even local resistance patterns. Now, treating kids, that always raises some extra considerations, right? We've had these historical concerns about drugs like doxycycline causing tooth staining or fluoroquinolones and joint issues. But for a disease as life-threatening as plague, the consensus is really clear. The benefit of using these powerful, effective drugs far, far outweighs the potential risks.
All right, let's talk about a big practical challenge, especially for any lab that follows UCAST standards. And that challenge is this. There are no specific clinical breakpoints defined for Yersinia pestis. So what do you do?
Well, the correct procedure, according to EUCAST's own expert rules, is to use the breakpoints for the broader Enterobacterales family. But, and this is the critical part, it's considered best practice to add a comment, just like this one, to the final report. It just makes sure the clinician knows exactly how you interpreted the results, that it's based on a surrogate, not a species-specific breakpoint. Okay, let's shift gears to our final, and you could argue most important section: infection prevention and control. All this diagnostic work is great, but it has to be done safely. So let's look at the protocols for handling this pathogen.
In the lab, safety is everything. Yersinia pestis is a risk group 3 pathogen, period. Now you can do that initial specimen setup at BSL-2, but only if you're working inside a Class 2 biological safety cabinet. The moment you're working with a live culture or doing anything that could possibly create an aerosol, it becomes mandatory BSL-3. This is exactly why that heads-up call from the clinician is so incredibly important.
Over on the patient care side of things, the precautions you take all hinge on the clinical syndrome. For bubonic or septicemic plague, standard precautions are fine. But the second that pneumonic plague is even a possibility, everything changes. You have to escalate immediately to mandatory droplet precautions. That's because it's the only form that can spread person to person through respiratory droplets, so containment is the absolute top priority.
And what if a high-risk exposure does happen? Say, close face-to-face contact with a pneumonic plague patient. Well, the protocol is a 7-day course of post-exposure prophylaxis to prevent infection. Ciprofloxacin is usually the go-to drug for this.
So all of this brings us to a really critical question for the future, for everyone in this field. We're now starting to see multi-drug resistance in Yersinia pestis, and it's often carried on plasmids that can be easily transferred. So the big question we have to ask ourselves is, are our current strategies enough? How do we need to adapt to stay ahead of an ancient threat that's clearly learning new tricks? I'm really curious to hear your thoughts on this challenge of emerging resistance. Have you had any experience identifying or treating Yersinia pestis in your own work? Please share your insights in the comments below. We would love to hear from you. And if you found this briefing helpful, please hit that subscribe button for more explainers just like it. Thanks so much for watching.